Looks like we have a great number of attendees, so let's go ahead and begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Greg Bonnen from Houston Physicians Hospital, as he will discuss focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise, and we encourage everybody with any question whatsoever to go ahead and author that and provide it down in the question and answer part within your screen. As we conclude the presentation, we will have those answered and consolidated by Dr. Bonnen. So let me begin by introducing you to Dr. Bonnen. He is board certified in neurological surgery and a fellow of the American Association of Neurological Surgeons. Dr. Bonnen serves as the chairman of the board at Houston Physicians Hospital, located in Webster, Texas. Dr. Bonnen grew up in Angleton, Texas, which is South Houston, and graduated cum laude from the infamous Texas A&M University with a Bachelor of Science degree in biochemistry. He earned his medical degree at the University of Texas Medical Branch in Galveston, Texas, where he completed both his internship and residency. He also served as an assistant professor of neurosurgery at UTMB. Welcome, Dr. Bonnen, and thank you so much for presenting today, and the floor is yours.
Well, thanks, Dave, and it's really good to be with you. I'm going to give an overview of our treatment options for essential tremor and tremor-dominant Parkinson's, and the agenda just kind of gives you an outline of what we're going to discuss. And as was mentioned, really one of the most valuable parts of this webinar is a chance for people to ask questions. And I'll reiterate what Dave was saying. If you're thinking it, I can guarantee you that there are several other people that are thinking the same question. So don't hesitate to send us your questions, and we'll try to cover everything that comes up. So we're just going to go over some basic facts, a little bit of the background of focused ultrasound, who's a good patient for this kind of treatment, the outcomes that we have good data on and are experiencing, and then try to give you an idea of what it's like to have the treatment done and walk through the process with you for actually having the treatment on the day of the procedure. And then we'll cover insurance and the option now of having the second side done. So we'll go ahead and start with just some basic facts about essential tremor. And you can go on to the next slide. Yeah, so essential tremor is actually extremely common. We don't know exactly what causes it. Many people perhaps don't realize how common it is until they have it or someone they know develops it, and then suddenly they become more aware of all the other people in their life that actually are experiencing the same condition. In half of the cases, it may run in the family. We do see that, but it's not strictly hereditary. Quite often it happens without any hereditary pattern. And sometimes it's a nuisance, and maybe it kind of gets in the way, but it doesn't keep people from doing things. But quite often over the years, it'll just gradually get worse to the point that it makes it hard to do simple basic things like signing a check or drinking out of a coffee cup, or even just buttoning buttons or brushing your teeth. And that's when it makes sense for people to consider all of their treatment options, and not just medication, but even procedures like focused ultrasound that can really make a big difference in their quality of life. So there are many people that experience this. As was mentioned, it's as many as 10 million people in this country. And a lot of the time, what we'll see is that people will try medications, and we'll talk a little bit about treatment options, but they're not real satisfying, or they have side effects, or both. And they're a little bit reluctant to consider any kind of invasive or surgical procedure. And that's one of the great things about focused ultrasound is it opens the door for people to receive a treatment that otherwise they might be very reluctant to consider, that can really make a big difference in terms of their quality of life. You can go on to the next slide. Yeah, and this is just giving you a little bit of the statistics for the number of people uh, that are diagnosed with this. And we also mentioned on this slide tremor dominant Parkinson's, and that's a little bit of a longer conversation. We definitely are treating patients with Parkinson's. Parkinson's is a spectrum, if you will, and so some people may have uh, a very profound amount of tremor with their Parkinson's, but interestingly, many people have very little tremor when they have Parkinson's. And this specific procedure is highly effective for tremor. So for some patients, that may make sense. For other patients with Parkinson's that don't have a lot of tremor, then focused ultrasound for at least this specific target in the brain that we're talking about today may not be as helpful. So we have to evaluate each patient's case to see what makes the most sense for them. There's a possibility of this technology being used for some other targets in the brain, and we may get into that later or with questions. But at this point, while there's some hope for that, there are still issues around FDA approval for the other location that we would consider for Parkinson's, and then also Medicare payment. You can go on to the next slide. So as I've kind of alluded to, the first line of treatment typically is medications, and certainly many of the people on this webinar will have firsthand experience or have a family member who's tried any number of medicines, typically a beta blocker such as propranolol or primidone is also very common. We see a lot of anti-anxiety medications used. And for some people, they may offer a little bit of relief. And if your tremor is not too profound, then that may do it. That may be enough for you to maintain a reasonable quality of life. But quite often, as the years go by, the tremor becomes so profound that the medication just doesn't provide satisfactory control from the tremor, or people begin to have side effects from the medications. A lot of folks are trying devices that they can wear, and they, again, may be somewhat helpful, but they typically are not, definitive or real profound in the amount of relief that you can get from them. And that takes us to the possibility of doing some kind of a procedure. And I'm just going to give you a little bit of a broader background when it comes to surgical type procedures for tremor. Even though the technology is brand new, the idea of targeting a very specific and tiny area of the brain to alleviate tremor is not new. It's been around for many decades. And in fact, I think it was 1954, if I'm not mistaken, when the first procedure was done to try to help somebody with tremor. And that was born of the experience that when people had a very precise small stroke in the brain and they had tremor, their tremor got better. And so as doctors and scientists tried to understand what parts of the brain do what, they figured out, hey, this is an area that we can alleviate tremor if that area has an ablation or a small injury to it. And the issue was that at that time, the technology was obviously not what it is today. And so things were more invasive. And then there were also, sometimes more side effects or complications from that type of procedure. But that's been around since the 50s. And then, oh gosh, about 20 years ago, the FDA approved the use of stimulators, which is very much a pacemaker type technology. And we could place those to this similar target in the brain. And it works extremely well. It has some advantages that we can do both sides at once, and it's programmable and adjustable as the years go by. But the downside is it is invasive. We do have to make an incision and drill a hole. There is an implant that's placed into the body. And for some patients, depending on their other medical factors, the risk may be too high, or it just may be something they're not comfortable with, even if they would be a suitable candidate for that type of treatment. And that's where focused ultrasound has really matured as a technology that allows us to essentially achieve really great amazing results, but we don't make an incision, we don't drill a hole, there's no implant placed into the body. And what we're seeing is a lot of people that would have just suffered with debilitating tremor are now willing to consider doing this. And so that's been the most exciting and rewarding part of it. And we may talk a little bit more about this later or in your questions, but that's just kind of an overview of the spectrum of treatments. You can go on to the next slide. So this simply covers some of the milestones in the development of MRI guided focused ultrasound and gives you a little bit of a sense of the age, at least if you will, of the technology. You can see that it was approved by the FDA for treating one side back in 2016. Medicare decided they would provide payment or coverage for it back in 2018. And really, it's been in the last few years that the clinical experience has really ramped up. And then it was at the beginning of last year that we began to treat the second side. So to do a second side treatment, we have to wait 9 months. But in that staged fashion, if we wait 9 months or longer, we can now treat the contralateral opposite side of the brain. So you can go on with the next slide. Yeah, so this talks a little bit about, how it works. What is it that we're doing? And basically, the transducer is shaped like a semicircle. So you can imagine a half of a sphere. It's got 1,024 little channels that emit sound energy. And alone, any one of those channels doesn't really do a lot, but where they all meet in one very precise location, it generates heat. And we're able to control the amount of heat and the duration with the computer software that's used to operate the equipment. So what we're doing is an ablation using heat energy at this target deep in the kind of the middle of the brain, if you will, that is about the size of a pea. It's about 6 to 7, maybe 8 millimeters in size. And the fascinating thing is there's no anesthesia other than local anesthetic to numb the skin. And people see the results or the improvement right away. And in fact, part of what we'll do on the day of treatment is do some lower energy treatments where we're lining up the target, if you will, and then looking to make sure we're happy with the results. And then when we see that, we'll do a higher energy, higher temperature ablation to make it permanent. You can go on to the next slide. So we'll talk a little bit about who's a good patient to have this type of treatment done. And as we've been talking about, patients that have either essential tremor or tremor dominant Parkinson's and have not been able to be adequately controlled with their medications are good candidates for this type of treatment. People 22 years older for tremor or 30 years older for tremor dominant Parkinson's. We don't do sedation with this, but frankly, that's not been an issue in our experience. We've done over 260 of these now, and patients tolerate it really well. We do have to be able to communicate with the patient, and on occasion, we might have a language barrier that we have to work around, but it is important that we can get feedback from the patient as to what they're experiencing and how they're doing, while we're actually performing it. The issue of being able to fit into the scanner or stop the sonication button, really never found that as a practical matter to be an issue. It is done in the MRI scanner. We do use imaging for both looking at the anatomy and also measuring the temperature with what we call thermometry. So you have to be able to go into the scanner. Once in a while, we might have somebody that has an implant that is not MRI compatible. If most of the time that's not the case. And if you take pacemakers, for example, most of the current pacemakers have a mode in which they can be placed, and we're able to have the patient in the scanner. But you have to be able to be in the MRI scanner. And we also will do a screening of the anatomy of the skull, because sometimes the skull may be it may be constituted in a way that it dampens or blocks out so much of the sound energy that we just can't get a hot enough temperature at the target. And that's not dangerous, but it would prevent us from being successful. So if we don't think that we're going to be real, successful with the treatment based on the screening, then, we just let the patient know that it's probably not a good, or worthwhile treatment for them. But that's unusual. The overwhelming majority of patients are able to proceed with treatment after we've looked at the skull density ratio and the thickness and shape of the skull. So this just gives you a quick idea of the volume of experience. And so cumulatively, uh, all doctors and all patients together, we now have a combined experience with over 10,000 treatments, which is really good. I mean, that's a large enough volume that, uh, we've been able to learn a lot and really refine and improve what we're doing, and be very confident in the results and the safety that we can provide with this treatment. So we'll talk now for a few minutes about what to expect when you or your family member actually has the procedure. So it's an outpatient procedure. You would come in and go home on the same day. We have a lot of patients that come from out of town, and for that reason, those patients may come the day before, not to be admitted to the hospital, but simply because it would be too much to try to make that trip on the same day as having the procedure done. On the day of the actual procedure, people come in and we have to shave their hair, and there is an actual reason for that. If we don't, it will actually disrupt or interfere with the ultrasound. And so one of the first things we do is we'll get you all checked in, shave your hair, and we'll actually do what some of you may have already experienced, and that's just an initial uh, assessment that day of the tremor. Of course, we've already assessed it before that day, but as a baseline for the day of treatment, you'll draw spirals in a straight line and write your name. And then we'll go to the MRI suite. Once we get to the MRI suite, we'll attach a stereotactic head frame. And these frames have been around for decades, and we'll use them for other procedures to actually calculate the target coordinates for a given treatment, and use them to place an instrument down to a very specific target. In this case, we're really just using it to keep the patient's head perfectly still. And that's a question that we get a lot. People get a little bit concerned about their head tremor and whether or not they're going to be able to do this. And the frame completely takes care of that. We've literally never had a problem with patient movement. So the whole purpose of the frame is it keeps the patient perfectly still. So if you cough or sneeze or adjust your shoulders or your arms or your legs, nothing bad is going to happen from doing that. And so once we get into the scanner, in our experience, it now takes us about an hour. It could be a little bit longer than an hour. It could be a little bit shorter than an hour, but the treatment lasts about an hour. And typically that'll begin with us just taking some pictures. So it's just an MRI at first. And then we'll do 2 or 3 actual ultrasound treatments. They're very brief. So that may be 11 or 12 seconds long in a more efficient skull, or a really long sonication would be, say, 25 to 30 seconds. So any one sonication is actually a fairly short period of time. And after we've done a few to make sure that we're happy with the way everything is aligned and we're happy with the targeting, and we've had you draw your spirals in straight lines and write your name again, and we've looked for improvement and made sure there are not problems with side effects, then we'll do typically 1 or 2 additional uh, sound treatments to make the improvement permanent. After that, you'll get up from the MRI table, we'll remove the head frame, and then you go to a room, visit with your family for about 30 to 45 minutes, and then people are able to leave the hospital. We are typically doing an MRI postoperatively the next day, and that's pretty much it. For people that live out of town, our follow-up is virtual, so we'll follow up with you the next day, and at 2 weeks, and at 3 months, and you don't have to travel other than for the actual procedure itself. You can go on to the next slide. So, what to expect? I mean, that's almost kind of like saying, well, why would I Why would I do this? Uh, we're looking for a pretty remarkable improvement in tremor. And uh, I was a little concerned in the beginning as to just how much we could expect. And we would tell people 60 to 90% relief of their tremor. I would say in our experience, it's typically a lot closer to, 90 to 95% than 60%. Another common question is, when do you notice a difference? And the answer is you'll notice a difference literally during the procedure. So it's something that you can see right away. We've not had anyone develop an infection, and because it's not an invasive procedure, I don't expect that we ever will. There's no radiation, there are no implants, and it doesn't require anesthesia. So this makes it very attractive for a lot of patients. I would say generally, this is very general, you can break patients into maybe three categories. There are those for whom maybe this isn't a great treatment and DBS or something else might be better, depending on if they maybe have Parkinson's and they're uh, reasonably good risk for having DBS and they're not tremor dominant. On the other end of the spectrum, you may have patients that just have a lot of complicating medical problems, and the pacemaker type technology just is not an option for them. And focused ultrasound is really the only option that they've got from a treatment standpoint besides medicine. And then there's the patients in between, which is a huge group that really have a choice. Either one could be very effective for them, and it comes down to the patient deciding, with us explaining to them all the possibilities and the risks, what they feel most comfortable with. But that's a little bit of what to expect from the procedure. You can go on to the next slide. Yeah, and I think one other thing that we will talk about, and you just see a video here showing some before and after from some patients that have been treated, and that is side effects. And so we have to mention that you could have side effects from this, even though most patients do very well. The most common one is people will tell us they feel a little bit unsteady on their feet, and that would typically mean that they list a little bit to the side that we treated. So if we treated the right arm, they would feel like they lean a little to the right, or if it was the left, they'd feel they lean a little to the left. That happens about 25% of the time, and it is almost always transient. So in the days and weeks to months to follow, it just gradually dissipates. Numbness or tingling on the side that we treat, not on the other side, but on the side we treat, is something we see less frequently. Uh, Rarely people could have a little bit of apraxia, meaning that they feel like their fine motor skills or their coordination isn't quite as good as it was before the treatment. And then dysarthria, which means they feel like it's a little bit hard to get the words out. And sometimes the patient will say they feel like they're having a hard time talking, and they'll sound fine to us and to their family, but they know they're working a little bit harder to make the words come out. All these things are typically related to some swelling around the target. So if you can imagine depositing heat to this pea-sized area, and the technology's amazingly efficient that it can be so precise in doing it, but there's still a little bit of warming in the adjacent area, and that'll create some swelling or maybe some temporary effects in that surrounding part of the brain. And then as that goes away, the side effects will dissipate. So you can go to the next slide. Insurance, really, very practical, important question. And we've had very little trouble with insurance. Medicare covers it. Most of the major insurers are now covering it. So it's pretty well established that this is a standard of care. So we don't have a big problem with insurance. But for each patient, we always check on that before scheduling. And we'll also make sure that we know what the patient's obligation might be. In other words, what portion might not be covered by insurance, so everybody's fully informed of their insurance coverage and any financial or costs that they may have, having the procedure. Second side. So when we first started to do this, it was FDA approved for only one side, which still could make a huge difference in someone's life. But if people were really affected on both sides, it'd be a little frustrating that you couldn't come back and do the other side. And the reason for that was to make sure that it was safe to do the second side. And a clinical trial has been done that demonstrated the safety and the effectiveness of doing the second side. And so we're able to do that now. We do wait at least 9 months, and that's to make sure that we don't have increased problems from doing the second side before the first side has had an opportunity to settle down, if you will. But we are able now to do the opposite side. We just have to wait at least 9 months before we do the second one. And this is an overview of the clinical trial that was done that demonstrated the safety and the effectiveness of being able to do the second side. And in that study, they had treated 51 patients. We've treated a fair number of them now ourselves. I'd say a couple of comments. It's one, it really is an identical procedure to do, um, relative to the first one. So most patients having the second side done actually find it easier because they simply know what to expect. So it's just a lot less stressful and there's less anxiety associated with it. The second thing is it's pretty rare with us, in our experience on the first side, to have anybody have difficulty with their speech. I think it's a little bit more common with the second side, but still typically a transient thing that they may experience. And you can go on to the next slide. So I'm not, that may be the end of the slides. I'm not sure what this is that we're seeing here, but I'm happy to take any questions that you guys may have.
Dr. Bonnen, this is Dave. We do have a handful of questions, and I do want to encourage all of our participants, if there is something on your mind, as Dr. Bonnen said at the beginning, chances are it's on the mind of somebody else as well. But here you go. So if you would, please review once again, talking about focused ultrasound in both head tremors and voice tremors.
Yeah, that's a great question and a really common question. So the experience is that focused ultrasound works amazingly well for tremor in the hand and in the arm and even in the leg, although it's less common that patients come in complaining about tremor in their leg. But for the head and voice, we don't have as much success, and that's with both focused ultrasound or with DBS or with medications. It's just much more difficult for us to treat. So it's very frustrating, but the primary reason we would do this is to help people with the tremor in their extremities and without a big expectation of improvement in voice tremor or head tremor. Anecdotally, we'll have some patients tell us that they really believe that their head tremor has settled down. But most studies that I'm aware of, and certainly our experience, is that we don't really have great expectations for relief of head tremor. The big relief that we see, the big improvement in quality of life, is with typically the upper extremity.
Very good, thank you. Can you speak again to the failure of medication? Because it appears that can get complicated, both what are frontline medications, secondary medications, and again, just to kind of underscore what a patient should expect in that regard.
Well, look, I mean, I'm all for patients trying medications, and for some people, that may be enough to allow them to have a good quality of life. But most patients, as the years go by, simply find that the medication doesn't adequately control their symptoms, and the tremor becomes debilitating. So we've never really had a medication, to my knowledge, that was highly effective at controlling essential tremor or, well, tremor dominant Parkinson's is a little bit different. It may be that, carbidopa, levodopa in its various forms, at least in the initial stages, can be, very helpful for that. But whether it's beta blockers or primidone, anti-epileptics, anti-anxiety medications, they're minimally effective. In some instances they're not effective at all. And then sometimes people also have side effects from them. And so what happens is people will either end up just living with their tremor, or they'll consider having a treatment like focused ultrasound or DBS.
And to tag right along with that, after treatment, will my medications be eliminated?
Yeah, that's a great question. And so the answer is a little bit complex. So first of all, we always have to make sure that, let's just say, for example, you're taking a beta blocker, that you're taking it only for your tremor. Some people are on it because they have hypertension, or they may have some other cardiac reason to be on that medication, in which case they're taking it for two purposes. And from our standpoint, sure, it's fine to get off the medication with respect to tremor, but we have to check with the cardiologist to make sure that that's going to be okay in terms of blood pressure or any other condition that beta blocker is being used to treat. The second consideration is, if you have tremor on both sides and we treat one side, the one side will be great, but the other side is still untreated. And so then it's a quality of life decision as to whether you're getting enough benefit from the medication on the opposite side that you still would like to take it. And from my standpoint, there's no reason to take these medications for tremor after the treatment has been done. But again, we got to make sure you're not coincidentally taking it for a second purpose. And you do need to consider, if you've only had one side treated, is the other side affected enough and getting enough relief from the medicine that it would still make sense for you to keep taking it.
Great, thank you. This is an interesting one. My son is treatment refractory at age 16 with debilitating essential tremor. Is there any chance focused ultrasound will be approved in the near future for under the age of 22?
That's a very interesting question, and I don't know if there are studies underway to demonstrate that a younger population could be safely treated with this technology. The other thing is, we really want to understand, is it essential tremor, or is there some other underlying process causing the essential tremor? And for somebody that young, and if they're otherwise healthy, you might also really consider DBS, because that would allow for adjustments in programming that can simply be done in the office as the years go by. Which, by the way, is another interesting point, that you can actually repeat focused ultrasound. So you could do an ablation later. Let's say that somebody had a focused ultrasound treatment, and 20 years later, they were experiencing a recurrence of the tremor, and it was enough to really bother them. It is possible to actually repeat the treatment. Of course, it would not practically come into effect maybe in an older population, where 20, 30 years down the road isn't as much of a concern. But the short answer is, I don't know if it's going to be possible, at least on label or with FDA approval, to treat people under 22. Whether or not there's an investigational study that a person under 22 might qualify for, I'm not sure. We would just need to get more information, both on the patient and on the availability of maybe doing this as an off-label or investigational use.
Thank you. Once again, people inquiring about the side effects as far as complications, during the procedure. Could you just go through that piece again, what they might experience, and then pretty much how it will dissipate?
Yeah, that's a really important question, and something that we would always visit with the patient and their family about before actually doing the treatment. And in terms of what you would experience, and I wouldn't call this a side effect necessarily, but there are things that are really common. So during the actual ultrasound treatment, not during the whole procedure, but during those seconds where the sound transducer is actually operating, that 11 to 25 seconds, People will tell us that sometimes they feel like they're floating in space, or they feel like they're doing a backflip, or they may tell us they feel heat across their forehead or across the back of their head. That's extremely common, and it goes away when the sonication stops. So when the equipment stops, uh, those those symptoms dissipate. So I don't necessarily call that a side effect. It's just something you experience during the actual treatment. When people first sit up, so you're lying down during the treatment. When we're finished, we'll have the patient sit up. They'll say they feel kind of dizzy or wobbly, and that's completely normal. And just within minutes, that will settle down, and that pretty quickly resolves. So again, not really something I would consider a side effect, but more something that you would experience just during and immediately after having the treatment, and that goes away. In terms of what we would more, or I would more label side effects, that would be things like feeling wobbly or unsteady on your feet, which is statistically, again, 1 out of 4. So 75% of the time, you're not going to experience that, but about a quarter of the time you will. And the degree to which people experience it will vary, and that can depend a little bit on their response to the treatment, but also, how steady they are before. So, for example, somebody that is already using a walker and is prone to falling before we ever do the treatment, they don't have a lot of reserve. So if you make them just a little bit less steady, they are going to notice much more that they're unsteady. Whereas somebody that is extremely independent, doesn't need a cane or a walker, they're perfectly stable on their feet. They may be aware that they're a little bit off, but they have enough reserve that it doesn't profoundly affect them. The biggest thing when it comes to unsteadiness, from our standpoint, because it resolves over time, is we just want you to be aware of it and be careful, because we don't want somebody to just assume that everything's perfectly fine. They're a little unsteady and they fall, and then they hurt something completely unrelated to the treatment in the brain. So we just want people to be careful. The second thing would be numbness or tingling. And interestingly, when we see it, which is a little unusual, it tends to be more in the lips or the tongue, again, to the side we're treating. So if we're treating the right side, it'd be on the right side, left side, it'd be on the left side. You could experience it in the fingertips or in the hand. We almost never see that. But that's another side effect that you would have. And, sometimes people will tell us, so let's say they play the piano or they use a screwdriver or other types of fine motor skills that they may have in a hobby, that the tremor is better or completely gone. Their strength is good, but they just feel like their dexterity is not quite the same. And again, that's something that will typically improve with time, and not everybody will experience that. And then I think the other thing that's worth mentioning is what we call dysarthria, or a little bit of trouble with speech. Again, not a real common side effect, but definitely something that we know from this target location over the years people may experience.
Very good. These two questions we can kind of couple together. Again, it goes back to the rationale as to why my head needs to be shaved. And can you please explain again how sound waves penetrate the brain?
That's a great question. And, I'm tempted to say that we shave your head because my head is shaved, but that's a bad joke. That's not true. But the reason is that the sound waves must travel efficiently to the target in order to deposit the heat energy at the target. So anything that's going to disrupt the transmission of those sound waves is going to prevent us from being able to achieve the goal of depositing the heat at that tiny target in the brain. It wouldn't be dangerous, it just would be unsuccessful. And so that is the primary reason for shaving the head. Now, the other thing is that uh, within the transducer around the scalp is circulating uh, cold water. Okay, and it's degassed or deoxygenated, and it serves some purposes. One is the transmission of the sound. The other is cooling around the scalp, because the transducer will generate a significant amount of heat. But ultimately, and we may have a graphic that we can pull for another time. But ultimately, if you can imagine sound coming from roughly 950 to 1,000 different directions. And I say at 950 to 1,000, there are 1,024 elements that could be on, but in each patient, some of them will be turned off just based on that patient's anatomy. So typically we'd have about 950 to 1,000 of them that are actually on and emitting sound. And there's no single one of them that is going to generate enough heat to create any effect. But where all of them collide in the exact same location, that deposits enough energy to release heat that is, say, 56, 57, 58 degrees Celsius, which is hot enough to ablate that target in the brain, which is one thing I hadn't really mentioned up to this point. With essential tremor, the thought is there are a group of cells that are overly active in a different lower back part of the brain, and they're sending these messages that are hyperactive to a relay station. And then from the relay station, the messages are relayed to a part of the brain that's controlling movement. So the area that we're targeting is actually the relay station. And so what you're doing is targeting a very precise point in that relay station, several millimeters, again, about the size of a pea. All of these ultrasound waves meet at that target. It releases the heat, and the heat ablates a small population of cells in that target location. And that's how the procedure effectively works.
Thank you. Two additional, well, we still have a laundry list, but I'm trying to couple these together. Uh, I've had bilateral hip replacements, left knee, replaced my forearm. Are these implants considered MRI safe? And then to tag along with that, my father is 97 and has limited heart capacity. His stability has gotten worse over the past 5 years. His medications are not working. Is he a candidate at this age?
So the first question, and Dave, you broke up a little bit, so I'm not sure everybody could understand, the question
It
or the
was,
questions.
it was, I have,
Dave, hey Dave,
yes,
we're having a really hard time hearing you. I'm not
Yeah,
sure if internet is not working well or not. So I don't know if you want me to just go ahead and run down these right now. Can you hear me, Dr. Bonnen?
yeah, and so hey, let me just answer as best I can, and then
Yeah.
we'll deal with that. So, the first question involved implants, and I think the question was, hey, I've had a knee replacement, a hip replacement, I've got some implant in my arm. Am I going to be able to do this? And so I would answer that two ways. First of all, our experience is that the answer would be yes, you'll be able to do it. So knee replacement, hip replacement, if you've had a fracture of a forearm or wrist and they had to plate it, I've never seen those become a problem. But the second part of the answer for that is that for every single case, we check that out, right? So we're going to want to know any implants that you have in your body, and we're not going to just take for granted. We're going to check and make sure that it's going to be okay. But I think the short answer is if you're talking about a joint replacement or some type of instrumentation in the spine or in a bone in the arm or the hand, we've not seen that is a problem. And then the second question was a little bit tougher. It sounded like somebody may be advanced in age who has a lot of difficulty with their gait currently, and whether they would be a candidate. And I honestly probably need a little bit more information to really be able to answer whether or not this would be something that made sense for them or not.
I can go ahead and just reread that question for you to see if that helps at all, Dr. Bonnen.
Sure.
It says their dad is 97 and they have limited heart capacity. His stability has gotten worse over the last 5 years, and he is not on Tremor meds because they just stopped helping. So they're wondering if focused ultrasound could potentially help him.
It could, and that's a pretty advanced age, and so it would just depend on doing an assessment of, is it worth it for them, and if the tremor is really debilitating, and he's able to, communicate and interact, it could actually make a difference for him. But again, we would just need to assess that. So age is usually not the limiting factor in our experience. And so now, 97, that would be one of the older patients that we would have considered treating. Having said that, people are living longer, and if it can work and they have a meaningful quality of life, then I wouldn't rule it out just because of age. And the last thing I would say is, if they're pretty unsteady, there's an interesting threshold here where obviously, we want people to be mobile and independent. But if they're already pretty immobile, but let's say they can't even feed themselves, you can't make them less immobile if they're already immobile. And so the risk of instability, if they're already not independent, isn't as meaningful. Whereas if you have somebody who can get around and be independent, but they're pretty unsteady, and you make them a little more unsteady, that's a bigger consequence for that person.
Right, right. I don't know if we let Dave help. I will do this next one and then we'll see if Dave can. Does fuss help with freezing?
Does what help with breathing?
Does fuss help with freezing?
Oh,
I'm
focus.
assuming, yeah.
Rigidity.
Oh, with rigidity.
Well, the question here is freezing, meaning I'm thinking
Oh,
that it's
freezing,
like,
freezing.
yeah.
I see. I thought you said breathing. Okay. Yeah. Well, so freezing and rigidity are two different things. Freezing, when I think of somebody asking about freezing, that's typically in the context of Parkinson's disease. And what'll happen is, over the years, patients will start to have trouble with their gait, and they'll get to a point where it's literally as if their feet are frozen and stuck to the floor. And sometimes they'll get up on their tippy toes and bounce up and down, or if they're in a really crowded space, or if they're in a doorway, their feet will freeze on them. Focused ultrasound isn't going to help with gait freezing in somebody with advanced Parkinson's disease, at least not really in my experience. Medication may help with that. DBS can help. The reason the stimulators might be able to help is because we can target a different location in the brain that would be more useful for that kind of symptom. Now, rigidity, and I'm not even sure if somebody asked about rigidity, but rigidity is different. And so with thalamotomy, which is the target that we're talking about for tremor, we actually do see relief from rigidity from this same target that we're using for tremor.
Dave, do you want to talk real quick to see how you're doing right now? If you're good, we can let you keep going. If not, I'll just keep going.
How does it sound?
Still bad. Okay. Initially, do you require a visit and MRI done there at your location? And is there one-time treatment, or does it have to be repeated like the same time over time?
Yeah, those are excellent questions. And so the first is that no, you don't have to be evaluated locally. And we have people coming from other states, from all over Texas, which is a very big state. So we have really become pretty proficient at visiting with people and evaluating them virtually. So in a format like we're doing right now, where we would actually be able to see them and assess them. And then in terms of any pre-treatment imaging, that is easy to do locally. And we simply, tell the imaging facility or hospital close to your home what specifically we need them to do. They do it. They send us the data, and that's just not been a problem at all. So the only time people have to travel is for the actual treatment itself. It's not required that people travel before or after that. So we can do an assessment remotely, and we can follow up with you remotely as well. So that's not been a big issue. And what was the second question?
Nope, that was it. That was
Okay.
it. I have more for you though.
Well, I
Um,
thought there was a second besides whether they had to be evaluated in person.
I don't think there was a second part of it. Let me just see. I'm just looking for it. MRI done there. Oh, and is this a one-time treatment or does it have to be repeated the same
Yeah.
side again?
Yeah,
Good question. Sorry
that's a
about that.
real important question, and I think that the that's a tougher one to answer, but the practical explanation that I would provide is that what we're seeing is that for years people have excellent relief of their tremor. Now, we talked about early that it was in the 1950s that this was first done with a different technology. And even in the 90s, when I first started doing this kind of procedure, we were more refined in how we could do it, but we would make a small incision, drill a hole, put a probe into the brain, heat the tip of it up, and take it out. So effectively, you ended up with the same thing. So the point being, this is a newer technology, but the end result is actually something we do have experience with. And what we see is that the results are very durable for many years. However, I think the longer you follow somebody out, the more likely you are to start seeing some recurrent tremor. So at 5 years, you're probably not going to see very much, or you may see none in a majority of patients. But at 10 years, at 15 years, at 20 years, at 25 years, the number of patients experiencing some recurrence and the significance or the degree of the recurrence is going to increase as the years go by. So anecdotally, and this is just, not like a large case series, I have one patient that actually was a general surgeon. That's what he did professionally. And in 1994, he had this same treatment done, but without focused ultrasound, obviously. It was done with the older technology where an incision was made, a hole was drilled, a radio frequency probe was put down to this same target, and the guy did beautifully. He did amazingly. He finished his career as a general surgeon, but 28 years later, the tremor had come back and was debilitating, and we treated him with focused ultrasound, and he did fantastic. So that's one example. However, it is literally the same as repeating the ablation, and I think it also illustrates that you probably will get many years of relief from it, but if you live long enough, 30 years later, you're probably going to have recurrent tremor. And it's probably going to be very mild in the first years that you notice it, but as time goes by, it will become more significant. So this isn't like, in our experience so far, we almost never are doing a second treatment in the same place, but I think that's because we've only been doing it for a few years. If you would ask me 10 or 15 years from now, it'd probably be a little bit different story, and we could even statistically tell you with more precision what percent of patients are going to reoccur and what percent of patients will reoccur enough that it's worth it for them to have it treated again.
Thank you. This one, my wife has an internal TENS battery and buttocks wires running alongside the spine. Would she still be a candidate for focused ultrasound?
Yeah, that sounds like a spinal cord stimulator, and the answer is that might be a problem, but we would have to check on the specific advice. And we literally not only check with the manufacturer, but we get the serial number, and we know the exact implant, and so the model, and we would track that down. But it is possible that if it's a spinal cord stimulator, that which is a little bit different than a TENS unit, that could prevent us from being able to proceed. But we have to check it to know exactly what it is.
This person is asking about health insurance, and I don't know how comfortable you are answering those questions, but I'll read it, and if not, we can send them to somebody to get some more answers. They currently are under United Healthcare, and when they called, they currently do not cover this code. Would it be better waiting until I'm covered under Medicare, currently retired, but on my husband's health insurance?
Yeah, my advice, I mean, what I would do is that I would let us run the traps on that, because that's what we do. And we have a whole team of people that will look into that and make sure yes or no, that's actually accurate. Because our experience is that most commercial carriers, and that typically includes United, are actually covering it. Of course, different employers may have different policies, and so we do have to look, for each specific patient. But I wouldn't just take it at at face value that they're not covering it. I would allow a team of people that actually do this every day for a living to look into that and get the answer for you.
This one is very simple question, but it's a good one. How long does focused ultrasound last?
Well, so that's really what we've been discussing, is what is the rate of recurrence and over what period of time. And so it's going to vary based on the patient. And in the initial years, you're going to see statistically a very low rate of recurrence and a very minor recurrence. But if you follow patients long enough, 10, 15, 20, 25 years, I think you're going to see a higher rate of recurrence, maybe mild, but then as the years go by, more noticeable or more significant. And that's based on the experience we have with using other technology to accomplish the same result of a thalamotomy. But with focused ultrasound, we haven't been doing this for 25 years. So we don't have, 15, 20, 25-year data to precisely tell you statistically X% will recur, and X% that recur will recur to an extent that they decide they want to have another treatment done. But certainly in the early years, the results have been excellent.
Thank you. How does a patient describe their level of tremor? What is moderate, low, and severe? I don't know if they're asking if there's like a level, or if there's I think they're just wanting to understand how you come to an equal of what is considered bad.
Yeah, so that's a very fair question. And there are actually rating scales, believe it or not, that can produce a number that allows us to kind of to scale the severity of the tremor. And part of that is a questionnaire where we ask about how it impacts or influences everyday life and all kinds of tasks. And then the other is having you actually do some drawings and looking at how good or bad those drawings are. And then we're able to rate it based on that. But I think a more practical element that we have to factor into this is, how does it affect your life? And, is this something that makes you a little uncomfortable, but you can literally do everything that you want to do? Or is this something where you have to drink out of a closed cup with a straw, because otherwise you'll spill whatever it is all over yourself, and you need help feeding yourself because you can't get a spoon or a fork to your mouth? I mean, the other thing, frankly, is we've had people that have professional concerns where maybe the tremor is not so debilitating that they can't drink out of a cup or feed themselves, but it's debilitating enough that what they do at work becomes compromised by their tremor. And so the value, the benefit to them of getting relief from that is very significant. So these are the factors that have to be taken into consideration when you're saying, well, how severe or how bad is the tremor?
Right, right. Dr. Bonnen, I just want to touch base with you at 6 o'clock. We still have several more questions. Are you still okay for a few more moments?
Yeah, I'm fine.
Okay, I just wanted to make sure before we kept going. This next one has to do with being claustrophobic, and I completely understand this question. Yeah. For the MRI, how far does the patient go into the MRI? To the shoulders or to the chest? So this is somebody that's obviously nervous about that.
Yeah, that's a great question. And I'll give you my observation on that in a little bit of a funny story. So in our series of patients now, probably close to 270-ish, we have not had one person that could not do this because they were claustrophobic, which is really fascinating because it is an issue with MRI. And yet there's something about this whole experience that even patients that are claustrophobic have been able to do it. And there are some other factors that might play a role in that. One is it's not like having an MRI. And there's a lot of other distractions. There's other equipment. We are constantly in and out of the room with the patient. I think that's a little bit of a factor. A second issue is that the scanner that we're using is a more current model, if you will. So the bore, in other words, the size of the opening is larger than some of the older models that were more narrow. And then along that same line of thinking is that the length or the depth, if you will, of the tunnel is shorter. So it's not as long of a tube, if you will, that you're going into. And when we're doing the procedure, the longest anybody would be in there is about 10 minutes. The rest of the time, patients are slid out from the magnet so that they can write or draw or rest, or we can make adjustments, whatever it is that we're doing. And then during the actual sound treatments, it's just seconds that the treatment occurs. A patient might be in there for 5 minutes and we do 3 sound treatments. So unlike an MRI where you go in there and you're still and you're there for 20 or 30 minutes or more, you're not in the magnet more than about 10 minutes at the most for any part of the treatment. So I think that makes it more tolerable for people. So we've not had anybody that wasn't able to manage. And then we had one patient that unknown to us was very concerned and anxious about this, and I would have reassured him they didn't need to be. So the funny thing is this guy was so motivated to have the procedure that before he came in and without asking our advice, he would lie on the floor and stick his head in a bucket so he could condition himself to being in a closed space because he wanted to be trained and able to have this procedure done. And he did great, but I don't know if it's because of his training with the bucket on the floor or not. So I don't really recommend that. I don't think it's necessary. It's a fair question because people are claustrophobic, but we have not had somebody yet that couldn't successfully complete the treatment because of claustrophobia.
And Dr. Bonnen, just so that people understand, the patient holds something in their hand when they're in the MRI, correct? So that if they're uncomfortable, they can squeeze that and you guys will come in and check on them right away. So that is
that's right. So correct. What and what you're referring to is there's there's a built-in alarm system for the equipment that we're using, and the patient has in either hand, right or left, a ball that if they squeeze it, it stops everything, and we come in and we get them out of the scanner. We've not had anybody squeeze the ball because they were claustrophobic. We've had people accidentally squeeze the ball because they got distracted. The main thing we tell people about is you may experience some nausea during the treatments. We used to say that all the time. Honestly, we don't see a lot of nausea. That seems to be, pretty unusual. But on the rare event that somebody got so nauseated that they thought they were actually going to get sick, we would want to definitely stop and get them out of there. And so that's the primary time that people would use the squeeze ball. But you're absolutely correct. If somebody was in the scanner and they just couldn't tolerate it for any reason, if they squeeze that ball, everything's going to stop and we're going to come in and get them out of there. So you do have not only the ability to communicate with us, but you have the ability to stop the procedure at any time. But the good news is that almost never happens.
This next patient is 82 and she has type 2 diabetes, high blood pressure. Her weight is 178. Would she still be a good candidate for the procedure?
Yeah, those are extremely common and really just not a problem at all.
Perfect. How is the tremor determined to be related to Parkinson's or just essential tremor? How do you figure out the difference, and is the outcome different?
Yeah, it's a great question. And basically, a couple things. One is the whole history, the clinical history, the story for somebody with essential tremor versus someone with tremor dominant Parkinson's is usually different. A lot of the time, or at least most commonly, people with essential tremor are going to tell us they've had tremor for a number of years, for a long time, maybe even their whole adult life, and it's just gradually gotten worse. Parkinson's tends to progress over a little bit shorter period of time. So it may be still years, but it's not going to be decades in the usual story or the usual history. Now, in the very beginning, let's say somebody's only noticed tremor over the last 12 months or 24 months. At that point, it may be difficult to distinguish between tremor dominant Parkinson's and essential tremor. Another difference is that patients with essential tremor will suffer with tremor, but they don't have other symptoms or other consequences from the essential tremor. Patients with Parkinson's will have difficulty initiating movements. We call that bradykinesia. They may have difficulty with their gait, which is something that we talked about earlier when we talked about gait freezing. They may be more unsteady on their feet. They may have rigidity. So there are other symptoms associated with Parkinson's besides tremor alone. And then the last thing that I'll mention is the response to medication is very different. So there are medicines specifically for Parkinson's that may help a patient with Parkinson's that would not produce any positive benefit for somebody with essential tremor. And so that becomes another feature that allows us to make that determination. And actually, I guess one other thing, there is a type of scan that we now have for Parkinson's that can also help to provide some useful information as to whether it looks like Parkinson's or whether this is essential tremor. So we have a number of things, everything from the clinical history, the whole story of how this has progressed, whether other symptoms they have, how they respond to medications, and then a little bit on what we call a DAT scan, a type of imaging can also help to delineate that. In terms of the response, they both respond well from the standpoint of tremor relief. The Parkinson's patients may be a little bit tougher than the essential tremor patients, but both respond well as far as eliminating tremor. But the other symptoms of Parkinson's for this specific target are not going to respond as well as the tremor response. So to the extent that you have tremor dominant Parkinson's, it'll help you with your tremor, but it won't help you with a lot of the other things that you may have in association with your Parkinson's.
Thanks, Dr. Bonnen. So next one is, I am not on medication. I have better days and some not so good days with my ET. Does it make sense to bypass the medication route and go straight to focused ultrasound?
Yeah, that's a fair question. I would say most of the time we like for the patient to have at least had some attempt at treating their tremor with medication. Sometimes the insurance may actually ask or require that of the patient. Having said that, not to sound cynical, I don't see a lot of patients that find the medications hugely rewarding. And so I do feel like sometimes it's a little bit of, it's something that we do and we ask people to try, but it's not quite often effective enough to make people feel like this was really something that's going to control their symptoms and they're not interested in further treatment. But I think it's worth the conversation. I think it's worth at least trying the basic medications that we usually do. Because, if you get enough relief that it's not gone, but you feel like you can enjoy life and do the things you want to do, that's good. So it's probably worth a try. But over time, it's unlikely to be the result that you're looking for.
This person uses medication, carbidopa, levodopa for several months and found it minimally effective. I have not used it in 8 months now. Should I try it again or really see the difference?
Yeah, so that is one of the most common medicines used for Parkinson's. And it's tricky because some people don't respond well, but they still have Parkinson's. Some people get side effects from the medicine, so they don't tolerate it well. Some people get side effects like dyskinesias as a result of it. And, I wouldn't just try it without touching base with your neurologist first. That would be my advice. It may or may not be worth it for you to try it again, but that's worth consulting with your doctor who's treating you for Parkinson's and figuring it out from there. I mean, you'd really need more clinical information to provide that kind of, advice, because in some cases it might make sense, in others it might not.
Right, right. This is an interesting one. I've experienced vertigo in the past and worked with a physical therapist to reduce episodes. Would the treatment make my vertigo worse or more frequent?
Yeah, that is an interesting question. And our experience is that we're not seeing patients complain of vertigo afterwards. And so I wouldn't expect that it would make it worse, but it's not a completely illogical concern that it could. But we're not seeing vertigo as an effect of the focused ultrasound. So I think it would be fine, but I wouldn't 100% discount that. But is that something that we have seen? No, it's not a problem we've run into.
This one just has to do with, is there any exercises that are recommended to slow the progression of essential tremor that you know of?
I'm not aware of any physical exercises that will slow the progression of the tremor. I mean, we know what tends to make it worse. So fatigue will make it worse. Caffeine will typically make it worse. Stress, and that could be emotional stress, anxiety. It could be a physical stress. People have another illness that they go through, and these things will all typically exacerbate someone's tremor. So when they're well rested and they've eaten and life is good, the tremor may not be as bad. If any of these other factors come into play, the tremor is going to be worse. And but I don't know of physical exercises specifically that alleviate the tremor.
And this next one is just wanting to make sure they understand you. They said, do I understand you correctly in saying that it is not recommended for someone who is predominantly with head tremors? Their whole body shakes. They wake up every day feeling nervous, like they've had too much caffeine, but nothing to eat. So they're just asking if you're basically saying this probably isn't the best for them in that case.
Yeah, I think the point is that the tremor that you experience in your arms or hands could get better, but if your primary concern is the head tremor or voice tremor, then it's not worth it if that's it. Now, if you say, look, I've got tremor everywhere, and if I could just make it go away in my dominant hand and arm, even though I'm still going to have it in these other places, that's worth it to me, then that's a different story. But if the primary focus is the head or the voice, then that's not worth it.
Yeah. How long till after the procedure till you can drive?
Yep, that's a great question. And uh, I don't personally think there's a simple answer for that. A lot of the time people will say you shouldn't drive for, say, 2 weeks. But here's what it really boils down to. There's not anything about driving that's going to change the treatment that we're doing. So I'm not worried about that. The issue is very simple, very straightforward. We want you to be a safe driver. We don't want you to have an accident. So riding the car or operating a vehicle isn't going to affect what's happening in your brain. But if you're feeling under the weather, you don't feel like your reflexes or coordination are good, we don't want you to have an accident. And this will vary from one person to another. So you could have somebody that within days feels really good and they feel like they can drive as safely as they could before. And you could have somebody else that takes longer than a couple of weeks before they feel like they're a safe driver. So the bottom line is being safe driving the vehicle. It's not that being in the vehicle or operating the vehicle is a problem. It's that we need to know that you can do it and not have an accident.
Which this next question kind of goes along with that. They're just asking if they were to do this procedure, would they still be able to do traveling and flying and going on cruises and things like that? And
yeah, I mean, we have people fly home the next day, so traveling is really not an issue at all.
this person has had several falls, and one of them, they actually received a brain bleed from it. They seem to be okay now, but it was 3 different falls. Would they still be able to get this procedure?
So in all likelihood, that would not be a problem if it's been a significant, length of time. So if somebody had a hemorrhage last month, we wouldn't treat them at this point. But if that's something that happened in the past, we'd repeat the imaging, see resolution of the acute injury. That wouldn't be a problem with doing the treatment. In terms of the falls, it would depend on why that person is falling, and are they still a fall risk, and does that factor into the decision of doing the treatment? But it wouldn't be a contraindication. So this would not prevent them from having the treatment.
We just have 6 more left, and they're somewhat short, but they're really good ones, so I don't want to not do them. I've heard that you have to be sedated for the screening MRI. Is that true?
That's not true. Yeah, there's no reason for sedation unless you just want to be sedated for the MRI, but there's no value in that from my perspective.
And then does this procedure disqualify you from other treatments?
Yeah, really good question. And the simple answer is no. So you could have focused ultrasound, and well, this is going to be a long answer. Although it's unlikely, you could go on to have DBS. Now, let me add a couple of caveats to that. I've been doing this long enough now that I've seen what we did surgically before putting in stimulators, and now we're kind of coming full circle to doing ablations again, in addition to stimulators. So in the mid 90s to early 2000s, I actually had patients that had been treated with pallidotomy or thalamotomy, but typically pallidotomy, another type of ablation, who would come in, and this was after FDA approval for the stimulators, and I put them in and they did really well. So I actually have the experience, even though it's been 20 years, of having patients who've had an ablation and then had high frequency stimulation, and it works, and it helps them. So it definitely does not prevent you from doing that. It doesn't prevent you from taking medications. It doesn't prevent you from having the procedure repeated in the future. However, if you're interested in some type of investigational protocol, so like a research study, it could be that the parameters of the study wouldn't allow somebody who's had this treatment in, because they want people that just haven't had that confounding factor. So that's an unlikely event, but I guess that's the one scenario that I can see where it could be an issue, is maybe it keeps you from trying something in a research protocol. And then the final piece, which isn't really the question, if you've had DBS, you can't have focused ultrasound unless the DBS implants are removed. So I'm not aware of anyone who actually has stimulators in the brain having focused ultrasound. There's some technical reasons why that would be a problem. But if you've had focused ultrasound, you could have the stimulators put in the future.
Great. Okay, we're down to just, actually, I've grouped them, so we have 2 now. This is a great question too. Why does the tremor seem to be worse when the hand is closed or gripping something?
Yeah, that's not unusual, and there are different kinds of tremor. And people will a lot of the time tell us that the more tension they have, for example, then the more it brings the tremor out. That's just part of the underlying nature of their tremor, and it's not strange or abnormal, but unfortunately that is common.
And then the last ones here is kind of 2 we're going to put together. It's and I don't even know, Dr. Bonnen, if this is something that you can answer or want to answer, but what meds do I need to try first is part 1 of the question. And then they're also asking, if they were to do focused ultrasound, does focused ultrasound actually affect your memory?
Yeah, the last question is that with respect to memory, there's no evidence that I'm aware of that it affects memory. It's not going to make it better. It's not going to make it worse. It should be the same afterwards as before. With respect to the medicines, they're basically 2 standards. One is the beta blocker class, the metoprolol, propranolol type medications. The other is primidone. I don't personally have a huge bias towards starting one or the other. You probably would, if you're not taking anything, only start one, just so you can tell what the effect is. If you start 2 at once, then you might not be able to distinguish the impact of one versus the other. But I mean, that's something that obviously you would do working with a with a physician, and they can walk you through that.
So we have come to the end. I just want to remind everybody that the information to get a hold of Dr. Bonnen and his office and his staff is on the screen. It's been up the whole time. Dr. Bonnen is also scheduled for another webinar if you want to bring family members back or you have somebody else that you want to listen in. He's scheduled for another one on March 13th, I think it is. So you can keep your eye open for that if you missed it. And this is being recorded. His team does have recordings that they can also send over if someone's looking for that as well. So Dr. Bonnen, with that being said, is there anything you'd like to say before we hang up?
Oh, I just appreciate you guys being with us, and thanks for participating.
Wonderful. Well, with that being said, thank you, everybody. Dave, you want to say goodbye? Are you working? All right. Technical difficulties tonight. Well, we made it work. We made it work. So thank you, everybody, and have a great evening.
Okay, y'all take care. Bye.
Thanks, Dr. Bonnen.